Everybody. Thanks for having me today. I am out of town, so you're getting the virtual me. But just a quick introduction of myself. My name is Chris Hansen. I am married to Emily Hansen. I currently work as a physician assistant in orthopedic surgery in Round Rock and Cedar Park. We specialize in joint replacements, knees, hips, sports medicine, as well as spine surgery. So I feel qualified to speak on this for multiple reasons. One is I first started my career in the fire service. I worked up in Portland, Oregon. So I spent about 13 years on the street taking care of people as a paramedic and a firefighter. So I get to see full circle of where folks, I saw the injuries in the field for a very long time. And now I've transitioned to where we take care of them in the operating room and then in the hospital and in the office. And then I became more specifically trained in osteoporosis several years ago. And so in our group of about 20 surgeons, there's two of us that do osteoporosis treatment specifically, and I do the majority of it. So I got to see from initial injury in your home to seeing you in the emergency room to then seeing you in the operating room, the hospital, the office, and then lifelong treatment. So I get to see the whole cycle here. So with that said, let's get on to the presentation. Okay. Can you all see that? Mm-hmm. All right. So there's a lot of, these are just kind of general numbers to just get us in touch with what's happening out there. The data is somewhat old, and so we can just anticipate that there's going to be higher numbers than we're seeing on here. So 50 years and older is really what we're looking at. If you're having issues with your bone health under 50, you're likely have some sort of genetic disorder that we need to treat differently. But over 50, the big things we're looking for are hip fractures, vertebral or spine fractures, and wrist and upper arm fractures. That 10 million estimated with osteoporosis is probably about 15 now, I would assume. And then osteopenia or low bone mass, they're getting away from the term osteopenia and just calling it low bone mass. But I'm going to say that's an even bigger problem these days for multiple reasons. But again, we look at the numbers of 1 in 2 women versus 1 in 4 men will have an osteoporotic fracture over the age of 50. This is kind of a skewed number, mainly because most men are just either not treated for it or they have a fracture and they're not evaluated for it. So you would be surprised the number of men I see in my clinic who have a fracture, have had multiple fractures, and no one's ever brought up osteoporosis with them. And a lot of the time that's just due to the idea in medicine that women have osteoporosis and men don't. But I think as we, again, capture more data over time, we'll probably find that there's a lot more men that have it than we thought did. Specifically in hip fractures, these are a big deal. Yeah, we use the statistically, it's about 20 to 25% of folks will actually die within a year of a hip fracture. Now, that doesn't mean that the fracture caused something so significant that they pass away, but the reality is it's all of the, we call it sequela after the fracture, meaning that you are in a hospital bed for days to weeks, which can increase your risk for blood clots. And then you lose so much muscle mass during that healing process that folks have a hard time getting around afterwards. And then if you have other comorbidities like heart disease or blood pressure problems or diabetes, this just complicates that significantly. So that's why it's such a high risk of death with a hip fracture. The 1 in 4 become disabled, meaning that they're permanently on a walker or a cane or have limited mobility after that fracture. Then moving into a nursing home, again, that's primarily because of the things I just discussed at first, is because there's other things that limit them in the long term that they're not able to live independently anymore. And then, of course, isolation, depression. I mean, a lot of folks go from being very busy, very active, volunteering or working, taking care of grandkids and kids, living their lives, managing everything that they do, and that comes to a halt very quickly. And so it's difficult for the mental health side also. So specifically, again, with men, 80,000 hip fractures a year. Again, this is in 2006, so this data, there's more these days. All ethnic backgrounds. This is it's not a, it won't specifically choose one race over another. And in all ages, women specifically, if they have problems with reproductive health or hormonal imbalances, that can increase the risk. A hysterectomy will increase the risk due to the sudden decrease in estrogen production. So again, everybody's susceptible to this. So what is it? We look at the pictures there on the right and left, or the side by side. You think of bone like a matrix or a net. And so that bone creates these very small channels, but it creates that really tight netting of hard bone. There's a hard, flat, thin layer on the outside of the bone, and then there's this matrix on the inside of long bones. With osteoporosis, that matrix starts to disintegrate, and so you get these gaps. And you can just see very easily in those pictures, they demonstrate that how easy it is to fracture with the bone on the right versus the left. There's just not the density to that bone. And so, again, it's very obvious as how you can fracture. So after your mid-30s, you begin to slowly lose bone mass. When we're in our 20s, we turn over our entire skeleton every 2 to 3 years, meaning that old bone is broken down and taken and resorbed, and new bone is laid on top of it. So that slows rapidly after the age of 30, unfortunately, and then it just continues to decrease. Again, after menopause or hysterectomy, that will increase significantly for women. So, yeah, again, bones are living tissue. They're not static. They don't just sit there your entire life and then go away, hang out when we're dead. Two major cells within bone are osteoclasts and osteoblasts. And those two cells do a lot of work in breaking down and building bone. They need construction material. And so calcium is one of the major parts of that construction material to add density. Again, they build to about age 30. And then, so we can see the importance of, as kids, as youth, of not only is physical health important for a lot of reasons, but for bone health. That if we have kids who are inactive, have poor nutrition, that sets them up for trouble in the future. So look out for your kids and your grandkids. So our risk factors, sorry ladies, the number one, being alive and being female is a risk factor. Kind of for the reasons that we discussed earlier. Advanced age, again, this is going to be as there's wear and tear, and genetically, osteoporosis will present at a later age. Advanced age does not equal osteoporosis. Keep that in mind. So being thin and small bones, a person who just genetically again does not have a lot of muscle mass or bone mass is at a higher risk. Caucasian or Asian ethnicity, again, type, when we talk about people from Scandinavian background, they have a higher risk as well as Asian. And then a family history of osteoporosis. I tell people that genetics drive the bus. That will determine a lot of things for us in our health overall, specifically with osteoporosis. There's things we can do to try to limit those effects of the genetic, or of what's going to happen genetically, but genetics will be in charge. And then an active lifestyle or extended bed rest. That goes back to what we discussed with hip fractures, that if there's anything that keeps you in bed for a really long period of time, whether it's injury or illness, you immediately start to lose muscle mass and bone mass. And so that inactive lifestyle is the slower version of that extended bed rest. It's well known, astronauts go into space and they come back with osteoporosis. It's that weight bearing that's so important. So the risk factors, again, we talked, the menstrual history is just directly connected to hormonal changes. That's the issue there, as well as the estrogen deficiency, same thing with menopause or hysterectomy. History of eating disorder or strict dieting. If we're not getting the right construction materials to build the bone, your body can't just make it up out of nowhere. So as a child, if you were had an eating disorder or were malnourished, it will again present later in life, as well as if you continue to do that later in life. Low testosterone levels for men. It's not a direct correlation of testosterone versus bone density, but it is, again, being able to maintain muscle mass, energy levels, being able to exercise. That's part of it. And then the low lifetime of calcium intake. Again, without the construction materials, we can't build the building. Medical conditions specifically, bone fracture after age 40. That's just telling us that you're at risk for osteoporosis. That's unusual. I'll classify those fractures as regarding the mechanism of injury. What that means is that how did the fracture happen? I tell folks, if you fell off a building or were in a high-speed car accident, I'm going to expect some fractures, like a vertebral compression fracture in your back. If you tripped and fell on the sidewalk, or you picked up a heavy pot and fractured in your back, that's very different. So we have to be very specific in the mechanism, not just the fact that you had a fracture. Rheumatoid arthritis is a degenerative immuno disease that will break down joints and does break down bone. Hormonal disorders, again, we're not regulating the bone construction materials very well, and so they can't be deposited properly. Poorly controlled type 1 diabetes. Diabetes in general are a huge risk factor for a lot of different things, and again with osteoporosis. Lactose intolerance, if it's not the fact that you get your belly hurts after you drink milk, but it's the fact that you limit lactose containing materials, which are dairy, which are calcium rich. So if you're not supplementing from other areas to get that calcium and you're avoiding dairy, that's why lactose intolerance can lead to this. And then digestion disorders. If your gut cannot absorb these materials that we need, they can't get to where they need to go. So those are some basic risk factors. Medication, specifically corticosteroid use. And this is folks that take oral steroids or inhaled steroids. I give a lot of cortisone injections in my clinic. Every day I'll give multiple into shoulders or knees or elbows, ankles, that kind of thing. That's not what we're talking about. We're talking about long-term oral or inhaled use of corticosteroids. They just inhibit bone growth, essentially, in a very broad sense. So there's a specific type of osteoporosis called corticosteroid-induced osteoporosis. So if you have a pulmonary disorder, a lung disorder where you're using inhaled steroids for long periods of time, you should be discussing with your doctor, how am I preventing osteoporosis as I use these drugs? They are essential. So there is always a risk-benefit discussion you have to have with your provider of, if I'm taking this medicine on a daily basis to help me breathe, it's going to hurt my bones. So is it worth breathing or having healthy bones? I'm going to take the breathing side of it, and then let's mitigate the osteoporosis risk over time. Thyroid hormone, again, the distribution of calcium is part of that. Anti-seizure epilepsy medicines, diuretics. The diuretics are just the fact that you're literally going to pee out different minerals that are needed to build bone, and you just can't maintain a high level. Aluminum containing acids and hormone agonists, again, are a risk factor. So let's talk about, that's all the scary stuff. That's how we get it. That's why we get it. That's what's going on. Let's talk about how you're going to stay out of my office and only see me and Matt at HEB and not at work. So the balanced diet. So I tell people the recommended supplementation of calcium and vitamin D. It's 2,000 units of vitamin D a day and 1,200 units or milligrams of calcium a day. That's supplementation. Just take these things in your diet as normal. Vitamin D is from sunshine. Get outside. And then the calcium, again, is from your dairy products specifically. So again, here's the daily needs. These change. They have changed through the years. This is pretty much what we're talking about right now. Some people have a hard time with calcium pills. One, they're usually very large. They're big horse pills. So there's calcium chews, there's calcium gummies, those kind of things. That's a way to do it. We talk about splitting it up between 2 doses so you can absorb it better, 600 in the morning, 600 in the evening. Vitamin D, here we go. So milk, cereals, fish, and then supplements. But sunlight, that's really where you're going to get it. So, you know, put on a little bit of sunscreen to protect yourself, get outside and exercise. So here's the exercise component. This is what I believe in the most that is lacking from folks who are diagnosed with osteoporosis or at risk for it. We've just become more sedentary as a society, unfortunately. I'm always shocked by the number of patients that I have that have really never exercised a day in their lives. And it's not necessarily a conscious decision, or it's no one's fault. It's just maybe they weren't exposed to that when they were young, and so they don't know how to do it now. And it's difficult to start at an older age. It can be scary. You don't want to hurt yourself. There's a lot of reasons that people don't. So I'm going to show a little quick video here.
Barbara, everybody calls me Corky Rawlings. I'm 86. I've been lifting at the Strength Co for about 1 year.
I'm Grant Broggie. I'm the owner of the Strength Co, and I'm Corky's coach. I coach Corky every Monday, Wednesday, and Friday at 8:30 a.m. She is a family friend of mine. She, like all older people, started to lose function and kind of decline. I walked into her embroidery shop. She did some work for us one time. And she was bruised on the face, and I asked her what happened, and she'd fallen. So I told her, I said, hey, would you come to the gym? And explained some of the benefits of it, and she said, sure. When
I first came in here, I was definitely intimidated. It wasn't scary, it was just a challenge. I had never done anything like this before. The only exercise I ever did was walking, and so it was a challenge, and I've loved it, every minute of it.
We've kind of built up over time. When she came in, she would just do one movement, very light, just getting her moving. And then, it's been adding and adding. She's deadlifting over 100 pounds now. I mean, she crushes it. She's in a group class just like everybody else. She's got a bunch of friends in here. She comes to the socials.
Well, I love this gym because when you walk in, everybody says hello, and they give you encouragement, and you know you can do it because they're rooting for you. I would definitely recommend weightlifting to anybody my age, younger, older, anybody, but particularly the older people. It gives you confidence, it gives you strength to do your daily chores. It's a very positive thing, and I love it. I recommend it to anybody.
That was perfect. Thank you very much.
I like perfect. I did perfect, he said. Okay.
Started at 86.
Pull your chest up, stand with it. You can do it, Corky. Push the floor with your feet. Come on. Squeeze. Yep, stand all the way up. All the way up. All the way. Good. 3 total. All the way up. And down. Good. Take a rest. One more set of 3 and you'll be done with that.
How was that, Corky?
Heavy. Good. It's amazing.
So I was saying you're not going to get a lot of people at that age that are going to walk into a strength gym and ask to start training. So she said, her previous exercise, she just used to walk. And that's what most providers will suggest to their older patients. Just walk. That's the best thing you can do for yourself. I'm going to push back on that and say that's not the best thing. That's the basic thing. That's something you can do for yourself that's very helpful. It can keep you fit in a lot of ways, but are we doing everything we can to prevent fracture and to make you a healthier person, that you're it's an overused word, but more robust? We're going to keep you out of the hospital, we'll keep you healthier. So being strong in a lot of ways is really a key to increasing your longevity and improving your quality of life. And Matt's really going to obviously help you all out today and get into the specifics of that. Okay, so other things you can do for yourself: avoid smoking, excessive alcohol. If you're smoking, stop. Just stop it. It's 2025. Okay, we know what's going on here. Stop doing it. And excessive alcohol. So moderate to minimal alcohol intake is okay, but excessively, we run into a lot of issues, specifically malnutrition, dehydration. But then also, if you're cruising around a little tipsy, you're at a higher risk of falling. So just mechanically, we're at a higher risk there. So moderate your alcohol use. This is kind of honestly a little bit of a throwaway slide. Talk to your healthcare provider about bone health. There's a lot of undereducated providers who just genuinely are overwhelmed with everything else. So if you sit down with your primary care doctor and you say, I really want to talk about bone health, you might get a really educated provider who understands all this and can have a 20 to 30 minute conversation with you about medication use and exercise and diet. It's unlikely. You're probably going to get take your calcium supplement and walk, and then maybe we're going to order a bone density for you. So you might have to do some research on your own. You might have to do a little bit more and kind of push that. You might have to find someone like me who specializes in this in a sense. Unfortunately, the majority of my patients that I see are post-fracture. I don't do a lot of preventative, just the nature of the specialty that I'm in, of orthopedics. So realistically, about 99% of my patients I'm seeing them after their fracture. We're trying to prevent future fractures. So finding a provider who's educated about bone health and wants to help you is a really big deal. So bone density testing and medication. So I won't get into the real deep parts of the medication because there's a lot of conversations there, but the bone density test is really important. This is called a DEXA scan. DEXA is a good machine. It can measure bone density as well as fat and muscle. So you can find them at some gyms will have them. Those gyms will not do your bone density. They're just doing your muscle and fat testing essentially. But a bone density test, it is not perfect. It's not the end all be all. The bone density test is essentially interpreted by a machine, read by a human. So all it is really for me is a good baseline. Where do we go from here looking at this bone density test? I have definitely had patients who have had osteoporotic fractures and a normal bone density. So the paper or the study does not give us all the information, unfortunately. Who should get one? All women over 65, and I'm going to throw in there all men over 65. Let's get a baseline to see where you're at and what your risk looks like. If you're younger and postmenopausal, then yes, again, the postmenopause is the big deal for females. Postmenopausal women with fractures to confirm the diagnosis of osteoporosis and disease severity. So again, I'm going to throw men in this. You're never going to be postmenopausal, sorry, but if you're fractured, we need to know why. We need to know you've had that wrist fracture from a fall. You broke your hip. We need to know what's going on here. It's not just well, you're a man, let's let this, suck it up and let it ride. We need to know what's going on here. So spine collapse, yes. One of the signs of osteoporosis that people don't pay attention to is, are you getting shorter? Some people will lose multiple inches in height. Sometimes there's, it's postural changes, it's those kind of things, but sometimes it's because literally your spine is collapsing. And so that's an indicator that we need to look at this further and try to prevent it from getting worse. So if you notice you're losing height in any serious way, we need to take a look. You can review this again of the things we do to prevent and treat. But again, I think the highlight of this is that you're never too old or too young to improve your bone health. This does start as children, and you have to maintain this. We don't get a warranty on our bodies, right? We get one time with this. And so we have to be treating them with care. And that doesn't mean being very careful and not taking any risks. That means that we're trying to push those limits of our bodies and keep them healthy and strong, and taking care of them from a mental health standpoint and from a medication standpoint, nutrition and physical activity, all very important to keep you out of my office. Again, we talked about this earlier. Tell your friends an hour of activity a day. That's a tough one. You got to yank the phone out of their hands and send them outside, but they need to be doing an hour of physical activity per day. And again, prevention is the key. We've talked about this. I've kind of harped on this, that when you've come in to see me, it's too late. We're now digging out of a hole. You need to be taking care of this before you end up in the operating room, so we can reduce all those risks that come with this. So that is the presentation there. The biggest thing for me is that, again, I just want to say that prevention is the key. If you've got questions about it, there's a lot of good resources. There's a lot of supplements out there that want to sell you something. Be careful. There's a lot of claims made by supplement companies that are not reviewed. They're not peer reviewed. They're not reviewed by the FDA, all of those things. So if there's a supplement that says that it's going to prevent osteoporosis, I'd be incredibly wary, and not hang your hat on that. I'm gonna do a little piece for Matt here. I've been in and out of physical therapy since I was 15, and then as my profession, I deal with a lot of physical therapists. They are not all equal. I will tell you that right now. There are some really bad ones. There's some really good ones and a lot of mediocre ones. Matt's at the top end of that list. Very well educated, very dedicated to his patients, and goes above and beyond. So you're very lucky to have him there today, because he's going to spread a lot of knowledge. So pay attention. He does a great job.
Thanks, Chris. So it's I love what I do. I got started because I was an athlete and I had a bunch of injuries, little musculoskeletal problems, and then eventually a stress fracture, because I was a skinny little distance runner. You can't believe it looking at me now, but I was 130 pounds. I had beautiful hair back then. And but I was running about 17 miles a day on average from middle of high school till I was 22 and got married. 17 miles a day was my average, so about 110 miles a week, more miles than I put on my truck some weeks, because that was the way to pay for college, and my coach in high school kind of pushed me in that direction, and it worked out well. Paid for school, got to meet my wife, and really glad that happened. But I could have paid for school delivering pizzas, and all that distance running. We didn't know what we know now. Didn't lift weights, didn't eat correctly, and I got real skinny. I got to experience sarcopenia from malnutrition and overtraining. So I got to feel a lot of what some elderly folks feel, just with the ravages of time and neglect. And it's not fun. It's very painful. And that led me down the path of looking into strength training. And lo and behold, things felt much better. I got super jazzed about that, and I wanted to share that with all my athlete friends. And so I became a coach in the weight room, coaching how to train with weights for athletic purposes. I did that for about 12 years, got my master's degree in that. And then the 2008 housing downturn hit, and people's discretionary funds dried up a little. And so I was at the time running a private facility that would train athletes and adults that were more athletically minded. And I was really getting tired of it a little, and the writing was on the wall that wasn't secure way to provide for my family. So I went back to school to become a physical therapist. And that's a doctoral program. I went through that, and it was really neat. And I learned a lot about tissue types and looking under microscopes and looking at cadavers in a laboratory and learning about the anatomy and all this great stuff. But what I didn't learn, what I was surprised to find out, was that a lot of PTs and a lot of PT schools don't teach good exercise, which you would think, what are they doing? You know, so they teach the background sciences really well, but they don't really set up the future physical therapist for taking you guys or anybody from not knowing what to do and feeling really unsafe or insecure in this area to feeling like you know what you're doing, you're very safe, and you can go and run a program on your own. And luckily, the strength training background really supplemented or complemented that. And lo and behold, I get reviews from guys like Chris saying, hey, something's different about Matt's clinic and how they run things. And our patients keep coming back, not because they're hurt, but because they want to learn how to get stronger, and they've done a really good job. And so I get patients all the time that go from completely uncomfortable in this to having a little setup at their home or working out somewhere and getting really strong and doing neat things. And I'll tell you about a few, but there's some case studies I'd like to go through too at the end. So what is age-related sarcopenia? So mine wasn't age-related, mine was activity-induced and malnutrition, but sarcopenia is a lack of muscle. So just like osteoporosis and osteopenia is a lack of bone density, this would be a lack of muscle. So sarco is the Latin root for muscle or meat. So we're going to go over the diagnosis of sarcopenia, risk factors involved, health consequences, as in what can you expect or what could be going on in your life day to day if you have it, and then how do you reverse it? Mine's way shorter than Chris's because a lot of this stuff is the same. And so as we get into this, you'll see a lot of similarities. So how do you diagnose it? It has its own ICD-10 code, which is what a doctor or a PT or a nurse or a PA has to put down so the insurance will actually pay for you to get treatment. And so sarcopenia is a thing, a disorder that the docs can put down, and some of them don't know about that. In fact, I think last time we were in here doing this presentation, I think there was a gentleman in here who was in a medical field, and he didn't know. That was news to him. But so it's usually diagnosed with MRIs or CT scans, but they expose you to radiation. DEXA scans, like Chris said, are the next best option. Less radiation, pretty accurate, but not as accurate as the first two. Way cheaper. You could cash pay for one for about $100. And then versus an MRI, anybody ever had to pull out of pocket for MRI? Like 600, 2,000, depending on how many years ago. Ultrasonography, so ultrasound is beginning to be used for it. So that's still in the works, where they're determining how to quantify and measure different parts of the body, the thigh, the upper arm, the gluteal muscles, to decide how much muscle that person has. You know, are these areas representative of the whole body? And then a grip measurement device, which I forgot to bring mine. We have a few at my clinic, but there's normative data that says, you know, you can squeeze this much. You must be, you can put 80 pounds of squeeze on there. You must have some muscle. But they're making the assumption that force equals muscle mass. And that's an interesting thing, because there is a real strong connection between the size of the muscle and its output in force, but it's not always that way. What is important is, even if you have a little muscle, if it's pretty strong, if you can produce a lot of force, it has to pull on something. Think about that. A muscle pulls through a tendon. So this muscle has a little ropey connection to the bone called a tendon. The tendon pulls on the bone. Guess how that stimulates the bone to be denser, and now you have fixed your sarcopenia and your osteoporosis. So they go together. If you've got strong bones, you can have strong muscles. If you have strong muscles, you have strong bones. So they're not really divisible. Okay. Risk factors. So more birthdays. Yay. This is a factor, but it doesn't have to go together, because as we'll see, there's some a lot of people that are very strong, and they're not slowing down on their muscle mass or bone mass, but they have to keep it up. The big decline is in the muscle building hormones and the receptor sites. So we produce fewer of the hormones that, like we did when we were teenagers, when you just go riding a bike and hanging out with your friends, go dancing at night perhaps, and hey, that's a workout. You got some muscle from that. Our systems aren't that sensitive anymore, so the receptor sites are less receptive or less sensitive. When you do activity, your body isn't going to respond as well as it used to. And so you have to have a more organized plan. So the tissue sensitivity, the growth factors, which are little cellular mediators that the body puts out whenever you do hard exercise, the recovery goes down. So because we don't produce all the same hormones and all the wonderful things, and we probably don't eat as well, we probably don't sleep as well, you can't recover from said work as well. So it needs to be organized. And then the drive to be active, a lot of us, we just get busy. We get busy, or we just don't know what to do, or we're scared. It's a risk reduction strategy instead of building ourselves up. It's kind of like, I liken it to a retirement savings account. I could make more money, or I could spend less. So at a certain point in time, people think, I just got to spend less. But they forget about the making money part. They could go make more. We need to do both. We need to balance that out. So that is related to inactivity or a sedentary lifestyle, malnutrition, particularly low protein intake. And this is when I have the discussion every day in the workplace. And I'm not a dietitian. I don't claim to have degrees in this stuff, but I can tell you what I see. And what I see is those who prioritize protein, meaning beef, chicken, fish, eggs, pork, dairy products, those things, the animal-based proteins, are going to hold on to muscle better. They're going to recover better. And there's a whole slew of micronutrients that go in there, not just protein, that'd be a macronutrient, but magnesium, phosphorus, calcium. Anybody heard of creatine? So we hear about it as a supplement, but guess what holds the most creatine naturally? Red meat. Red meat, fish to a lesser extent, eggs to a lesser extent. So it's a naturally occurring thing. It's in our body. We need it to make ATP, or adenosine triphosphate, and have energy to do activity and to think. And so there's a lot of stuff out there. Have you read about the cognitive benefits of creatine? So it helps our brain function too. So make you quicker at the Sudoku puzzle. Then we've got comorbidities. So these, we'll go over these, but if you have a comorbidity, it's likely that you have less muscle. And we'll talk about why that is. Neurological conditions and cognitive decline. So if you don't go push yourself to do resistance training, weight training, there seems to be a correlation with earlier decline in cognitive ability. Memory as well, included. Medication. So does this look kind of like what Chris was talking about? Yeah, corticosteroids is a big one. So I got a poor patient. This lady's been on prednisone for a long time, and it's chewed up. She's had total shoulder, total hip, total knee, the big six. But she got off it finally. Her team of doctors found a different medication profile or setup, and she's done what you're going to do today or similar. And she slowly got to where she's going on riverboat cruises in Norway, and she's doing all this fun stuff. She doesn't have her old husband to hold her back anymore. May he rest in peace, but she's having a good time. But that came about because she got her medication in line, and then she got stronger. She can haul her luggage up the ramp to get on the cruise ship. She can put stuff in the overhead bin with artificial joints. So it's pretty neat to see. Statins is a big one that gets dismissed as a necessary evil, and so you usually it's your GP or your cardiologist that prescribes them. And I don't ever want to step in front of those guys. They got more letters behind their name and more years of school than me. I just know what I see, and what I see is tendinopathies, meaning tendon tears, tendon pain, and myopathies, muscle pain, muscle tears, in about 2 to 3 months after they start taking Lipitor or Crestor or one of those. There's a new one called Repatha that seems to have less of those problems. But if you're on one of those, talk to your doc and see if the symptoms match, and maybe they can switch out a different one. There's really a scant amount of evidence that it actually helps women. So beware if you're on one, or if you have a friend that's on one or a family member, ask them to go look at the actual research, because it seems to lower LDL in males, low density lipoprotein, or the bad cholesterol. It doesn't do as much in females, and the connection between higher blood cholesterol and heart attacks and strokes and things is actually not very good. So it's kind of like they say that high cholesterol is a indication of body inflammation. It's not an indication of a problem. It's the ambulance or the fire truck that comes to the fire. It's not the fire itself. Inflammation's the problem. And we'll talk about how inflammation is related to sarcopenia. So beware the statins because they shrink your muscle, they make your muscles ache, they make your tendons ache. Smoking, not good. Inactivity, malnutrition. Alcohol. So alcohol is an interesting one. So those who imbibe a lot, it takes up time for your liver to process, which means it's not helping you recover or process food. So you literally just put somebody else in line ahead of your nutrition, and it's going to take from you. And alcohol makes you urinate more, which is a diuretic, which Chris talked about. There's drugs called diuretics. Well, alcohol's a diuretic. It makes you urinate out a lot of your micronutrients, and then you're not recovering as well. So the consequences. So if you don't have as much muscle, you have increased chance of falls and fractures. So in school, PTs, we learn about this. So balance, we could say the lack of falling. Balance is the combination of three systems where you're taking inputs from your environment through your eyes, your visual system. So it's important you don't want to fall, to keep your glasses prescription up or your contacts, right? So you can see, you got visual input. It's your vestibular system, your inner ear, which is going to get a little slower as we age, but it's our level. You ever used a level to hang a picture? So if I lean this way, there's little sensors in here that there's a fluid that stays level, and there's little hairs called kinocilia, and the hairs get swept this way and that way like seaweed in the ocean. And if I lean this way, the hairs get swept this way. If I lean this way, they get swept, and that's talking to my brain, which is talking to my body, saying, hey, we're leaning. And it's pretty cool. If you lean one way, you push through that leg more. If you lean this way, you push through that leg more. But you shouldn't have to think about that. It just happens. It just happens slower as we get older, okay? And then there's a third system called your proprioceptors, which are your pressure sensors in your feet, your toes, your ankles, your knees, your hips, your joints. They feel pressure. That gets a little weaker as we get older, and especially if you don't use it. But it can get better with weight training because you're pushing that system to experience more. So those are your inputs. Those tell you, hey, I'm out of balance. But what brings you back into balance? What corrects it? Anybody got an idea? Your muscles. So your muscles have to push. Yeah, it's more simple than you think. Your muscles got to push, or really they pull on the bone to correct the position to right you or correct you, to keep your center of mass over your base of support. So that's the definition of balance, to stay in balance. And so the muscles have to do the correcting. All this other stuff detects. Does that make sense? So because of the risk of falls, a lot of times with less muscle, people don't go out. They don't walk around. They don't go hiking with their grandkids. They don't go to the grocery store. They call the, what's the service, the grocery Grubhub or the whatever, to bring you, Uber Eats. They call in the food, and so it starts to slowly detract from all their activity. They don't go visit with friends. I know my dad is a great example. He will only leave the house to go fishing because he loves it, but he cuts down more and more of the activities he does with my mom because he's afraid of falling. And his lower half is really weak, and his upper half's getting heavier. Not good. Not a good combination, right? Compromised independence. So if I can't do things myself, if I rely on a walker, if I rely on a cane, if I can't get out of the chair myself because there's no arms on the chair, I'm going to avoid those situations because it's embarrassing or I don't feel good about it, right? Greater risk of hospitalization or complications with that. Sorry, it's covered up. So if you happen to have a fracture or some major injury that gets you in the hospital and you're stuck in a gurney or a hospital bed for a week, Chris mentioned, he alluded to losing muscle. So guess what you can do preemptively to start off at a higher amount of muscle so that if you know you're going to lose 10%, it's better to start up here, right? So really, your muscle mass is a savings account to sock away muscle for a rainy day. And also your organs, so heart, lungs, liver, spleen, brain, and not so much. Brain's made of other stuff. Skin, nails, hair, all that stuff is made out of protein and amino acids. You might have heard peptides. Peptides are a string of amino acids, not quite a full protein. If I go get injured, I get really sick. I got COVID real bad, actually, personally. I lost like 22 pounds in 2 weeks because I couldn't walk. I felt so bad. Couldn't walk, couldn't lift weights, couldn't eat. During that time, guess what I care about? I don't care about muscle so much. I care about my lungs, my liver, my heart, my kidneys. Those are made out of protein. So my body will steal from my biceps and my thigh muscles to feed and keep up those vital organs so I don't die. Kind of important. So it's really it's an extra savings account. And so people, you know, they get on bed rest or something, or they go to the hospital and they're laid up for a while. It's not the laying down that kills you. It's not even the muscle loss that kills you. It's that you had such little reserve that kidney failure, boom, it just happens so easy. Yeah, and your immune system too, the mediators of the immune system to fight off infections like pneumonia from laying down, you know, you kind of get backed up in your lungs. That's made out of protein. Your body gets protein from your muscles, so it's a storage tank. So enough of that. Decline in mental health and quality of life, we kind of already talked about that, but there's brain-derived neurotropic factors that get released, that get made and then released when we exercise. More so with strength training. Okay. Related comorbidities, osteoporosis, we talked about that. Type 2 diabetes, so you are, the person is insulin insensitive. Insulin helps grow tissue. Body fat helps store away carbs as body fat, helps store away fat as body fat. But insulin also helps you turn protein into muscle. So if you're not very sensitive to insulin due to diabetes type 2, you're not going to make muscle very well. So that's trouble. So we got to get over that, which is weird because if you start building muscle with strength training, you actually reverse type 2 diabetes. So they work against each other and can reverse each other either way. Obesity. Being obese doesn't necessarily mean you have less muscle. They just find that those who are obese tend to have less muscle. So it's more of a correlation, not a causation. Cardiovascular disease, if you've had a heart attack, my dad's a good example of that too. He had a mini heart attack. He's afraid to do things. Therefore, he doesn't push himself. Therefore, he doesn't stay strong. Doesn't hold on to the muscle. Frailty syndrome, that's kind of a cluster of different symptoms, including sarcopenia, osteoporosis, thinner skin, poor eyesight. There's a few other ones in there, but it's kind of a cluster of things. Okay, correcting it. This is the big thing. This is where I come in. So people get sent to me, and strength training 2 to 3 times a week, that's based on what you can recover from. So why do a third time if you can get the most out of 2 and you can recover? Be efficient, right? Increase protein intake. So this is an eye-opening one. So this is in kilograms, but let's do it in pounds. 1 gram of protein, because that's what all our food labels are in, per pound of the you want to keep. That's the easiest way to think about it. So I weigh 205 pounds. If I want to keep most of me, I probably want to keep about 185 of that, right? That's how many grams I need to eat per day. That's a lot. I have to think ahead on that. I can't just go by my basic appetite, which gets dulled as we get older. So to me, that's a 40-gram protein shake in the morning. That's well, let's go with somebody else. Let's say the you want to keep is 130 pounds, 150 pounds. Okay. If we broke that up into 3 meals, that's 50 grams per meal, right? That's a lot per meal. So most people have to supplement with a protein shake or drink milk or little snack here and there that's protein heavy. A palm size of steak is about 40 grams. So if I took my fingers off, that thickness and that size, 40 grams. If it's chicken, it's about 35 to 30 grams. So it's less dense. Fish is even less dense. It's about 25 to 30. If it's that much of eggs, it's about 24 to 25 grams. So it gets less dense from red meat to chicken to fish to eggs. Okay. Vitamin D supplementation. So just like bones, if you don't have good vitamin D, you don't make muscle very well either. Staying active. All general activity begets more activity. So you feel better about strength training if you don't sit on your butt all day, all week long. Improved sleep helps you recover from the strength training and make you feel energized for the strength training. And strength training helps you sleep better. So they're in this positive cycle going up, positive spiral. Staying hydrated. So a lot of people, I find this to be interesting. I get patients with chapped lips all the time, and especially in wintertime, cracks in their skin. I get that too. I love coffee and caffeinated beverages, so I have to back off, and I got to take my own medicine. But if you're dehydrated, you don't make muscle as well. And you're probably less energetic, because if you're dehydrated, you can't do a lot of the processes to think and to be active. So staying hydrated is important. Hormone levels, just like Chris talked about, balanced diet with micronutrients. Okay, we're going to get into some strength training here, some resistance training. I use those interchangeably. How do you decide what to do? So, and even a better question, why not just walking like Chris said? So he said that's not enough. I'll tell you why. It's not enough force production. It's not enough stimulus to the muscles, which pull on tendons, which pull on bones. It's not going to get it done. I don't know why that's still on the recommendations, because it's totally inadequate. Got people that walk a lot, they still fall and break bones, and they're still too weak to get out of a chair. And they're not independent. They're not living their best life. So we decide what meets the criteria for good strength training or resistance training exercises. They're multi-joint moves, multi-muscle group. They have a big range of motion, meaning they move from all of this instead of just little motions. Okay. Examples would be, well, we'll get into the examples, but there's some intentionally shortened motions for safety. We'll get into that. They use the most muscle mass possible. They need to be loaded. So at some point you want to get more than your body weight, because you want to be able to move your body weight easily. So how do we get to where that's less effort? We move our body plus something. Greatest generality, meaning it carries over to lots of life activities. Helps me carry my luggage, helps me carry my grandchild or my child, helps me mow the grass, helps me get out of bed and do chores in the house. Trying to think anything else. I had one older gentleman, he's in his 80s. He had a great definition of independence. He said, if I can put pants on standing up and not fall over. Yeah, I said, heck yeah, that's a great idea, actually. Yeah, walking the dog and it doesn't pull you off your feet. Yeah, and take a fall. Convenient to incrementally progress, meaning you don't do the same thing forever. So we'll start today at a pretty light weight, and this whole light versus heavy. Doc, should I do light weights? Should I do heavy weights? Blah, blah, blah. That's not the argument. It's what you can do safely with good form, and then each week you titrate it up just a little. You add 5 pounds. So it's not about this or that. It's start with what works for you, and then you slowly add more. So the whole argument of high reps, lightweight, it's a silly argument. Okay. These are patients of mine. This is my mom. Yeah, sure. Not in that position. she would hate that I would do it. Yeah. Yeah. Yes. 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 Should I repeat the question? Yeah. So Emily's asking, are machine-based cardio exercises like the elliptical, where you can change the resistance, or I would put a bike in there, cycling, yep, a bike, a rower, are those resistance training? Yes, to a point. So you can resist, right? But eventually, if you can do it for 10 minutes, it's not strength training anymore. That's 1,000 or more reps, right? It's yeah, there's some inertia, some momentum carrying it along, but it's also low enough effort that you can do it many, many times. So you could, I like to say, you can mimic the symptoms of a heart attack. You can sweat, turn red, and huff and puff a lot. I don't like that stuff. I mean, I like to walk and go play sports with my kids. I like to strength train so they don't have to worry about that. So I would say yes and no. Yes, there's some resistance by definition. Eventually, that should be so easy that it's purely cardio and it's not resistance. So at the beginning, people get strong from just walking for a few weeks. Riding a bike, their legs will get stronger. They'll show more muscle mass for about 6 weeks at most. And then you got to go more. And there's a limitation of how much you can crank up the resistance on a bike or an elliptical. Eventually, you'll hit the limit. Anybody know? Is that me? It's me. Oh, it was me. Somebody must have touched my truck. Yeah. Huh. Okay. Yes, good, excellent thought. So tell me again, Carrie just asked, is it the same problem or where you run into a limitation of the stimulus with bands? Yes. So if I have a band that takes 10 pounds of tension to open it up and I'm working my shoulders, great. Each week I do that, it gets a little easier until it's really ineffective at stimulating progress. And so that's the key. And if you saw that video that Chris put up there with Corky, they showed some little thin plates that she was using. She was warming up, but she probably started with less than that. You're going to start with less than that. My mom, who's 72, 3 years ago, started with 25 pounds, which I bet maybe we'll be at. She now, 3 years later, so whenever they shut down the gyms for COVID, she started working out with me at my clinic 2 days a week. Real simple routine, took 30 minutes, twice a week, just twice a week. Started at 25 pounds on the deadlift, which is what these ladies are doing. And she's now at 155 pounds for a set of 5. Didn't gain any weight, lost 4 pant sizes, can outwalk and talk her friend when they walk every day. So walking's good, just not strength training. So since we're on that, this lady, another patient of mine, she's starting with 25 pounds on the T handle, this little thing we're going to make like arts and crafts. Sorry, let's try to stay in the picture. So they both started on the thing y'all are going to start on today. Real simple, easy motion. It's just a technical way to safely pick up something off the ground and put it back down. We'll do 3 sets of 5. Almost nothing. But you, week by week, session by session, you add a little weight and you slowly sneak up on yourself and you get enough stimulus to put on more muscle. You don't end up looking like a man. Everybody's worried about looking like a man. It took me a long time to look like a man. But you look like the stronger, better version of you, and you feel better. Your joints are more protected. Your clothes fit better. They fit, snug up here, less here. That's the sort of thing you end up noticing. People will say, "Oh, my pants are a little tighter here," but they're looser in the waist. That's a great thing. Waist circumference is an indicator of disease. It's a comorbidity of a expanding waistline. So, example, squats, deadlifts. We're going to go over deadlifts today. Presses, meaning pushing this way or pushing this way. Pull downs, rows, loaded carries. So walking with extra weight. So you can walk. That's where I say it depends. If I can walk for 2 hours, it's not much strength training. If I can walk for 30 yards with 50 pounds in each hand, that's strength training. So it depends. Grip work. So a lot of people, you ask me, Julie, yeah, but could it be better with some gentle strength training? I think it probably could. So osteoarthritis is coming for us all with more birthdays. Knuckles of the hand, elbows, shoulders, hips, knees, basically all the big joints. But it's not correlated with pain. Everybody thinks osteoarthritis equals pain. Osteoarthritis can be defined as joint changes and cartilage loss. But I've had people that have had osteoarthritis, 6 months later, they still have it on x-ray, but they got stronger and they feel better. They don't have the pain anymore. So what changed? Their strength and their muscle mass. Lower legs, so calf and ankle work, that's important too for balance and for walking. So we won't get into that so much today. These will sort of be involved with what we do. We're going to do a real simple 3-part routine. So it's not, so a lot of athletes, former athletes have this problem where they used to kick butt on the field or on the dance floor or whatever, and then all of a sudden injuries accumulate and then they shut it down and they don't know what to do. Yep. So you don't get to do the athletic cool stuff you did before. Sorry. Okay. But you do need to do something, and it needs to be careful and calculated, and we're going to go through that. So you can start the deadlift even today. Just start really light, and you're the barometer of how much. Right. So no symptoms, no pain is allowed. Pain is a great red flag alert system to tell you it's too much or something's not right in your form. Sadly, it's not easy to learn the perfect or proper form on these things. There's great books on it. I can list you all the great books. I've read as many as I can, and you can teach yourself or you can get a professional to show you. And it does help to have coaching on this sort of thing. I had to be coached. I got my master's degree in exercise physiology with a focus on muscle physiology, but I didn't know how to coach a deadlift. They don't teach that in school.
So much.
Yeah. So then what do you do now? How do you start? So that's the question you're trying to get at, right? Is where do I start? Yeah. So you start small. So, anybody ever taken the Dave Ramsey Financial Peace course? Yeah. So what does he do? He's got his baby steps, his debt snowball, right? Same thing here. You start with drink more water, try to work up to 2 liters, and none of it has to be like on day one. You work towards these goals. 1.5 to 2 liters a day. Your number of pounds that you want to keep, that many grams of protein a day. Those are our first 2 snowball steps. Dave Ramsey steps. The third one, strength training 2 to 3 times a week with a few compound moves, which we'll do today, done in a way that doesn't hurt, following what we'll talk about for proper form. Oh, okay. So this kind of gets to your question. So start with body weight or weight which you can perform the exercise properly, safely, and efficiently. We'll talk about what that means. Work up in sets of 5s for the compound moves. Your squats, your presses, your deadlifts, your pulls. Not so much so anything that isolates one muscle, you can do for way more reps. Anything that's multiple muscle groups that it has to be done in gravity, and you gotta, like squats or deadlifts, you gotta keep from falling over. Sets of 5 or fewer, which goes against a lot of the things you'll see on social media and comment. And why only 5 at a time? Because I need you to focus. I don't want you to think about lunch and your grocery shopping list and all the errands you got to run later today. You need to focus for 5 good reps. And if it's 10 reps, you're going to be distracted, possibly. I know I get distracted. I can't count that high. And then 3 to 5 sets, which you'll see we'll do 2 to 3 days a week. And you got to pay attention to what you can recover from. So I put a funnel on here because at some point, everybody wants to also know. So once they get started, they answer that first question, then they think, well, how do I progress? Well, you got to think about what do I bounce back from in 24 to 48, maybe 72 hours. But personally, I don't want to take 72 hours to recover. I don't want to feel tired for 3 days. I want to feel like, okay, the next day I felt like I worked out. Sure, a little sore. And really, if you stick to the same moves, that's over within 2 weeks. You get over the soreness. Soreness is not a badge of honor that says I worked out hard. Soreness is what happens when you start something novel. So you added in a new exercise, or you're coming back after a long time off, and then it should be done with in 2 weeks. Unless you're jumping around exercise, you're doing random acts of variety. That's another thing people do, and they really shoot themselves in the foot on their progress because they don't stick to a very narrow plan that carries over to lots of life activities. So for me, I stick with like 5 moves, and I don't deviate. I don't want to be sore. And I know my plan leads to, I do a sport, a martial art, and I coach my kids in soccer and the martial art. And I stand all day for work and I walk around. I don't get sore, but I want my strength training to feed those things. I don't want to be sore and have to recover too much. Does that make sense? Yeah. We're not here to just be worker outers, Yeah. We're doing it for a purpose. So, yeah.
Right.
That's a little more forward. Judy. Yeah. Sorry, I'm gonna keep moving around. Yep. And then if you just slide down the legs and get a hold, can you bend the knee a little or no? Or none? Yeah, do a little. Okay, and then go ahead and try to hold tight, keep the arms stiff, so you don't want to bend anything here, and you just push the floor to come up. Push hard through the floor. Good. So she's doing, yes. And when you come down, pull it underneath you. Pull it back. Yes. So she's doing kind of a stiff-legged deadlift, which is a variation that I would only have somebody do after they learn the full deadlift. But for you purposes, if you didn't want to have to bend the knee, you're still getting strength training for your spine, your shoulders, your arms, and your legs. So I would say for you, if that's how you do it and that works, do it. Okay. Yes, ma'am. So there's nothing wrong. You're going to feel a little more in the hamstrings and your butt than maybe somebody who bends their knee more. And that's okay if you just know that's you've dealt with this. Okay. Okay. How about try 4 more and let's see how that goes. Hold some breath in your lungs, push the floor with strong legs. And then on your way down, you want to pull it underneath you. Yes, that'd be number 2. Good. Good. Let's try one little modification. What happens if we put a chair behind you? And if you were ever scared of falling, you could put a chair back here. Have a seat, but still keep your feet where you are, and you can walk. Yes, ma'am. So start here. Okay, what happens if you lean your head out, and then you raise your butt up from the chair and then go? And I'm going to stay here to catch you in case something goes. And then push. Yes. So you just did it with some knee bend, but you had help. You had kind of a safety, and then back down to the chair. Yeah, you're avoiding loading up the right knee. Okay, but is it anything painful yet? No. Good. Then I would do maybe one more like that, and then you'll take a rest. So you're getting the full benefits just with a little safety buffer. Good job. Okay, resting. Well done. Yes. Yes. Yeah, for sure. So if you were to just stick with this 2 days a week, let's say a Monday and a Thursday. So you got enough rest time in between, and you just said, hey, I'm going to add 2.5 pounds each session for maybe 3 or 4 sessions. Then I'd go to just once every week adding some weight. I bet you'll get up to about 30 pounds in about 6 or 7 sessions, and you'll be amazed that you feel better getting in and out of chairs and out of cars. Yeah, you might be putting on pants one leg. Yeah, no, you can. Okay, that's not an issue because your leg is straight. Yeah. And then come down and get your handle. Okay, now you feel some tension in the hamstrings, and hold some breath in your lungs and push the floor with your legs. Push all the way till you're standing up. Good. And then on the way down, you're going to stick your butt back and swim it underneath you like you're pulling it underneath. Yep. And go 4 more. That's perfect. You've done this before? Yeah. You look like you know what you're doing.
My form is terrible.
No, you're doing it.
Very helpful.
Yeah. Good. Breathe. Well, she's doing a good job of picking her butt up to start each rep to get the slack out of the hamstrings. And last one. Good. That last one, did you feel your back a little more? Yeah. Okay, come back down. So I can tell, but if you felt your back, that means you're not pushing the ground. You're not thinking leg press the floor or push the earth down. You're thinking up, and you got to switch that thinking to save your back for long term. So good job. Yes.
Should you like wait so many seconds?
Excellent question. You should sit down and rest or walk around for about a minute. And then, and I start people at 1 minute. And in my clinic, there's a lap to walk. They have the rest lap. They take a walk around my clinic to just kill the time and get moving. As it gets heavier, you want more time because your body, your muscles have to regenerate ATP, adenosine triphosphate. And so they're remaking the jet fuel that does big, heavy contractions. And if you wait long enough, it makes it so much easier and safer. You skimp on the rest, you're doing cardio. It's kind of shifted more to the cardio, and you have really weak contractions, but you can do lots of them. But that's not what we're doing. We're weight training. Hence the 5 reps or fewer and sitting down in between. I will do heavy sets of deadlifts and sit down for 3 to 5 minutes and have half a sandwich in between mine. It's a different way to approach things. It's not go, sweat, huff and puff, but you could still be very fit and trim, and it carries over real life and you actually feel better. So
you do 5.
And then I go sit. Yeah, 1 minute, sit down. Now you could also go do an upper body move if you're trying to save time, if you're trying to compress and be more efficient. Yeah. You ready?
Sure.
Come on up. So 15 pounds. You guys are the best dressed deadlifters in the cutest shoes I've ever seen. Yeah. All right. Which is also good.
But I've lost every bit of muscle. Like not recent, the past year and a half, almost 2 years, I've lost like 90 pounds.
Wow.
And I was great. And then all of a sudden, like my muscle just like within like a month, I'm like, oh.
Yeah.
So I need to build it back up.
Yeah, for sure. Yeah, and that's the thing with any sort of weight loss, some of it's going to be muscle. So how do you hold on to more muscle while you do weight loss? Strength training.
And I mean, it was great up until a point, and then all of a sudden I could just feel it.
Yep.
Okay.
So yeah, get your handle and yep, you look good there. Hold some breath in the lungs. Back muscles are nice and locked in and you're going to push the ground. Push. Yep. Keep the arms straight all the way up. And then you bend the knees a little and stick your butt back and you bring it back underneath. Good. Do 4 more, just like that. That was perfect. Hold some breath in the lungs. Push the ground. Good. Between your arches. Think between your arch of your foot. Good. We may have your butt starting a little too high. So come down just a little. Yep, right there. And now push the ground and you'll feel like you got a little more front of the thigh muscle helping. But a little more efficient, like you had more muscle involved. Yeah, good. So that's how much a little inch difference can make. Yes, ma'am. Good. 1 more. You're doing great. Good. And there's your first set. Okay, leave it. Okay, so bring the weight. Let's bring it back just a hair. There you go. And so come about shoulder width. Looks good. Come down and get your handle. Pause. Okay. Knees back. Yep, right there. So butt up 1 more inch. There. Come right there. Hold some breath in your lungs. Tight grip. Push the ground through your boots. Yes. As you come up and when you go down, you're using this muscle group to keep it pulled to you close. Okay. Yes. Good. 4 more. That was perfect on the way down. You got it. There's 2. Yep. Take in some air. Hold it and push. 3. Butt a little higher. Yep. Lean into the forefoot a little more. Good. 4. 1 more. A little more weight into the ball of your foot. Yep. And go. 5. And come back down. You got it. Yep. Nope. And you kind of got squatty on the way down. Good. Good.